Right, a very good morning to all professors, doctors, and fellow students. Thank you for taking time to join us in this webinar today, titled Exposing Clinical Reasoning During Case-Based Learning. I'm Dr. Olivia T, the host for this session, and I'm from iGroup. iGroup is a one-stop station for information products and library technologies. Our ability to provide a full spectrum of related products and services with localized support from each of our regional offices establishes us as the key information industry partner in the Asia-Pacific region. Today, we are delighted to have the NEJM Healer team with us, and allow me to make an introduction. We have Mr. Matthew O'Rourke, who is the General Manager of NEJM Healer. And he has been with NEJM Group for the past 25 years in a variety of editorial and business roles. And the last decade, he has been focused on building solutions for educators. Our guest speakers, we have Dr. Nathan Stehauer. He is the Director for Internal Med and Pediatric Consult Service, Cleveland Medical Center. He's the Program Director also for Internal Med and Pediatric Residency at the Cleveland Medical Center, as well as he also serves as the Associate Professor for Internal Medicine and Pediatrics for the Case Western Reserve University School of Medicine. Our other guest speaker is Dr. Raja Ali. He is the lead editor for NEJM Healer. He is the Director, Innovation and Clinical Reasoning lead for NEJM Group Education. And he is also the Assistant Professor of Medicine for Harvard Medical School. So please drop any questions in the Q&A section of the Zoom webinar, and we will answer all your questions at the end of this webinar. So without further ado, I would now like to pass the floor over to Mr. Matthew to introduce NEJM Healer to all of us. Mr. Matthew.
Thank you very much, Dr. T. It's delightful to be here today and to be hosted by you and your team, and to have this opportunity to talk to all of you in your morning. Really appreciate all the time that people are giving to us today, and we hope to make it worth your while. Briefly, the New England Journal of Medicine is something that most of you may be familiar with. At 200 plus years old, it is the oldest continuously published general medical journal in the world. We're very proud of both the heritage of the New England Journal of Medicine and its innovation as a journal. And that innovation goes beyond the pages of that journal. We've launched a series of other journals, but also, as Dr. T noted, we've long been involved in medical education, and for the past decade have really focused on that with a series of products, including NEJM Knowledge Plus as an adaptive question bank, and NEJM Healer, which we'll be talking about today. And I am delighted. I think you'll get a very thorough overview of what NEJM Healer is from Dr. Raja Ali Abdul Noor. It's been a pleasure of mine to work with Dr. Abdul Noor over the past several years, first as a consultant and then as a colleague, to bring NEJM Healer to fruition. It really has been his vision and his passion driving this. And we're also, I should say, honored to have Dr. Stehauer as a member of our board, in addition to all of the qualifications that Dr. T noted. Dr. Stehauer is very involved in research and teaching around diagnostic reasoning in particular, and has done some very interesting work in that field. And so again, we're very pleased to have him here tonight and pleased to have him as a member of our advisory board. Very briefly, what we're going to do tonight, first principles, right, is to take a look at the big picture, look at the leading models for how clinical reasoning works, and how a case-based curriculum that incorporates both knowledge and reasoning can be beneficial to programs in training physicians. Then go on to demonstrate how NEJM Healer in particular provides deliberate practice and assessment of both knowledge and reasoning. And finally, explore how and where NEJM Healer can be used in the curriculum. I'm going to pass it over in just a moment to Dr. Abdelnour to start out, but I should note that we would really love to have your questions as we go through. You'll see that there's both a chat and a Q&A. Use the Q&A option if you can. Either one, though, we'll be monitoring. And at the end of the presentation, we'll go through your questions and try to address them all. And we love to answer the questions that are on your mind. So please feel free to type away as we're going through this. And without further ado, I will hand it over to Dr. Abdelnour.
Great, thanks, Matt, Dr. T, thank you. So the reason we're here and our drive to innovate and educate is to solve a central problem in what we do as clinicians is that we make mistakes. To err is human, and that's the title of a report by the National Academy of Medicine in the United States that really highlights the cost and prevalence of reasoning error and the impact it has on patient lives. And in fact, reasoning errors are common and costly. And in the United States, a 10 to 20% there's a 10 to 20% incidence of delayed, missed, and incorrect diagnosis, leading to over 100,000 deaths per year in the US alone. And we recently looked at data outside of the United States, including in Malaysia, where recent studies have shown that their incidents are very, very similar. Clinical reasoning. Now, the reason that errors are common is because clinical reasoning is hard. It's complex. I mean, if we think about it, the task of the clinician, whether it's a physician, a nurse, a medical practitioner in a rural clinic, involves within minutes going through hundreds of data points from a patient, whether they're complaints, physical exam findings, lab findings, using all that data to narrow from a differential diagnosis of potentially thousands of different hypotheses to only a handful, and ultimately one solution, one diagnosis. And so for us to be able to teach and solve that problem, we think that, and according to the National Academy of Medicine's goal, is to teach the diagnostic reasoning process in addition to knowledge. And this therefore to allow learners to learn how to think how to think, in addition to learning information and medicine. And all this is to really augment the clinical training with a greater case volume. Now, practice makes perfect, but you need more than just practice. You need deliberate practice. This is a figure that we've adapted from Erickson's work. You can see in the purple curve here that practice alone will improve clinical performance over time. Every time a clinician sees a patient, they improve a little bit. But it's really this assessment and feedback that is obtained after each encounter that can really dramatically improve performance. That assessment and feedback is core to deliberate practice and is central to our efforts as we develop Healer and to improve teaching of clinical reasoning. So now Dr. Stehauer is going to take us through the theoretical frameworks of clinical reasoning, what is clinical reasoning, and how we use that to develop NEJM Healer to teach and assess clinical reasoning. Nate, to you.
Thank you. Yeah, so I'll talk a little bit about some of the conceptual models and touch a little bit on the evidence that we've relied on as we've thought about the clinical reasoning process and the models that have informed the development of NEJM Healer. A lot of this begins with consideration of the dual process theory. This was made famous by Kahneman and Tversky and describes two basic cognitive processes occurring in parallel. System 1 reasoning and system 2 reasoning, as Kahneman called them. System 1 reasoning is what he termed thinking fast. This is non-analytical reasoning. This is unconscious pattern recognition. It's fast, it's effortless. It is not even a choice that we make. It's the way you recognize your friend's face without consciously reasoning through why their features match up with what you remember of your friend. It's, as clinicians, it's a pattern of reasoning that we use when we've seen the problem before, but it is, of course, then dependent on experience and a rich base of stored knowledge. In contrast, thinking slow, analytical reasoning is slow, it's effortful. It's reasoning when we know we are reasoning, we know we are thinking about something, and it is deliberate. And it's a mode of reasoning we use when we are confronting a problem that is new or challenging, when we're confronting a patient's case that we simply do not recognize. So how do these come together in the process of clinical reasoning? This is a figure from an integrated model by Pat Croskery, and from the moment of presentation, both system 1 and system 2 can be activated. Sometimes we recognize the patient's presentation. System 2 starts generating hypotheses, or system 1 rather, generates hypotheses for us almost immediately. But other times we encounter a patient scenario that's unrecognized, or it's particularly complicated, and system 2 kicks in instead. And of course, throughout the reasoning process, system 1 and system 2 go on to converse with each other. And clinicians use both patterns of reasoning throughout the clinical encounter. We cannot and should not aim to simply turn off system 1 or lean only on analytical reasoning in order to generate improved diagnostic results. In fact, the work of Jeff Norman and many others has demonstrated that strategies to simply shift clinicians into system 2 thinking on the assumption that analytical reasoning will correct the errors of system 1 reasoning have really failed to demonstrate any improvements in clinical outcomes or in diagnostic accuracy, I should say. And in fact, there's some interesting emerging literature that demonstrates that training students in combined reasoning strategies actually yields improved diagnostic outcomes compared to training or preparation in either system alone. So the key questions for educators are how to train system 1 to be more reliable and accurate, and how to adapt both strategies to improve our reasoning. I'm going to spend most of our time going through a slightly different model of reasoning, and this comes from Judith Bowen, and I would highly encourage anyone who's interested to read her paper in the New England Journal in 2006, describing an overview of the clinical reasoning process for educators. I'm going to add some of my own annotations here. The clinical reasoning process really begins with the phase of observation. This begins with the patient's story, but not just the story as static data, but the process of data acquisition. And the emphasis here on acquisition should make clear this is an active part of the reasoning process. And the feedback arrows demonstrate this process is not linear, but rather the process of acquisition is continually being informed by the diagnostic hypotheses being generated. Before jumping to hypotheses, however, there's an intermediate step to be considered, and that's the process of abstraction. Abstraction is how we generate meaningful, more generalized concept from the raw data that we're being confronted with. In a clinical encounter, this might be, for instance, reconceptualizing the raw data of a hemoglobin of 9, a mean corpuscular volume of 72, and a reticulocyte count of 0.6% as a hypoproliferative microcytic anemia. Abstraction is reframing the presentation of a man with crushing substernal chest pain that resolves with rest as typical chest pain or typical angina. Abstraction more readily allows the clinician to understand the significance of the patient's findings and to start generating hypotheses. The sum of the key concepts abstracted from the data is the problem representation, an extremely important step in the process of diagnostic reasoning that I'm going to discuss further a little bit further on. But from this abstracted data, we then interpret. And the process of interpretation, generating diagnostic hypotheses from the problem representation, we search our own bank of illness scripts, knowledge structures that we can activate in response to our problem representation, and then generate hypotheses which we can feed back to gather more data as we go through the process of script verification. The generation of hypotheses may lead to continually search for additional information to confirm our hypotheses. And at a certain point, we may decide that we have enough information that a diagnosis becomes our working diagnosis and leads us into decision-making, where we may recommend additional tests, suggest treatments, and other management choices. And finally, and crucially to the learning process, is reflection, which allows us to cement knowledge gained in our memory and improves performance on future cases. I'm going to talk a little bit more in depth about the problem representation because, as I alluded to, it's a core skill in diagnostic reasoning. It is a marker of diagnostic competence, and it is a predictor of diagnostic success. So a problem representation is really a mental model, and it is not static, but evolves in time as we gain more data in the clinical encounter. It is our way of abstracting from all of that data that Dr. Abdelnour mentioned that we encounter as we obtain data from a patient, and abstracting out from that the question, what is the problem we are solving here in abstract terms? In much of the literature, this is fixed in points in time as a summary statement. And there are really three main components to the problem representation. The what are the important symptoms or findings that define the problem? The when, the chronology, how this evolves over time. And not just the duration, is this chronic, is this subacute, is this acute, but really the understanding of the tempo and frequency. This is one of the most frequent pieces of feedback I give to my learners. Hopefully this simple graphic demonstrates that in 3 illness courses of like duration, you see very different subsequent courses which paint very different diagnostic pictures. And finally, the who. What are the relevant features of this patient in particular, in their background, their exposures, their age, where they have been and where they live, that may impact the probability of disease. I often simplify the concept of a problem representation for my learners as thinking about the search terms you would put into Google if you were unsure of what was going on with the patient and you wanted to generate some additional hypotheses, which is in some sense what we were doing cognitively. So what makes for high quality problem representations? How do we recognize these? One of the most important concepts is that high quality problem representations use something we call semantic qualifiers to highlight contrasting axes. Semantic qualifiers are the difference between describing someone with joint pain and describing someone with monoarticular arthritis or polyarticular arthritis. These axes allow us to differentiate important categories of possible diagnoses. You see, for example, here, placing a given patient in the quadrant of acute monoarticular arthritis immediately starts to generate a very different differential diagnosis than if I had told you to solve the problem of a patient with chronic polyarticular disease. And it turns out that one of the key markers of an expert problem representation is the number of and richness of the semantic qualifiers which they use. High quality problem representations, as an extension of their ability to abstract out significance from the clinical data, group findings by significance. A high quality problem representation will not list for you a patient with fevers and leukocytosis and night sweats and chills and an elevated C-reactive protein. Rather, they'll tell you that a patient has an inflammatory syndrome. Finally, high quality problem representations will focus on discriminating features that are central to an illness script that help to differentiate and define it from an alternative hypothesis. For instance, if you were confronting a patient with pharyngitis, the feature of malaise may be important to the patient, but the fact that the pharyngitis is exudative and associated with tender cervical lymphadenopathy will be much more helpful in differentiating the diagnostic possibilities. So why do we do this? It creates a mental picture and it helps us to reduce cognitive load, and it triggers the knowledge that is stored in our illness scripts to allow us to compare and contrast possible diagnostic hypotheses. I've alluded several times now to illness scripts. Scripts, as a more general psychological phenomenon, are high-level, pre-compiled conceptual structures. These structures contain very generalized sequences. These aren't examples of a specific patient that you've seen with a diagnosis, but rather These are prototypes that bring together the clinician's understanding of the range of possible presentations of a given illness. Illness scripts, these are events connected by temporal or causal relationships. In the same way that when you walk into a restaurant, your script for a restaurant is activated and you expect certain things to happen in a certain sequence. In the same way, when you encounter a patient with a heart failure, your illness script for heart failure is activated and you start looking for certain things and certain causal relationships. These are stored in our long-term memory, but they're activated as a whole and bring along not only the expectations of the possible range of presentations, but also activate linked illness scripts that we know to consider as alternative hypotheses. When your illness script for acute monoarticular gout is activated, so too should be your illness script for septic arthritis, for instance. A novice learner may activate only one illness script in a particular patient case, or perhaps none at all. Experts will often activate several illness scripts and are able to pull from these to compare and contrast between possible diagnostic hypotheses. Expert illness scripts encode probability and emphasize distinguishing features, which allow them to activate several illness scripts, and then as they instantiate those scripts, as they compare them with the particular patient data, are able to compare and contrast to evaluate the relative probabilities of each diagnostic possibility. And so System 1 and System 2 together bring the process of diagnostic reasoning to calibration. System 1 can actually conduct very high level, what you might term Bayesian reasoning, but in sort of a naturalistic way, through an intuitive assessment of probability as the clinician compares the features known in the illness script to the particulars of the patient's presentation. System 2 can also more consciously activate and engage in Bayesian reasoning and consider the likelihood ratios associated with each possible finding. And learners can enrich their illness scripts not only with the range of possible diagnoses, but by understanding the likelihood ratios and the probabilities associated with the patient's findings to enhance both System 1 and System 2 reasoning in the future. Together, System 1 and System 2 come together in calibration and assess the likelihood of a working diagnosis, or better, the probability of multiple possible diagnoses. This assessment of diagnostic probability is what allows us to move from simply diagnostic reasoning into decision-making, into the beginning of management reasoning. And decision-making begins with an assessment of probability, and for every possible diagnosis for a particular patient, a comparison between the assessed diagnostic probability and the threshold at which treatment would be indicated and the threshold at which testing would be indicated. We refer to these two as the threshold for treatment, the threshold for testing, or piece of RX and piece of testing. For every possible diagnosis, there is some probability threshold above which treatment is indicated even without further data. And there is some probability beneath which we can acknowledge that no matter how, while acknowledging that the diagnosis is still possible, the harms and the costs of additional testing are not worth pursuing. To put this in context, imagine caring for a patient with hemoptysis. After taking a history and physical exam, the clinician assesses the relative probabilities of 3 hypotheses: community-acquired pneumonia, a pulmonary embolism, or lung cancer. Now, each of these has a threshold, probability threshold of testing, but for each of them, it's quite different. The consequences of missing the diagnosis of community-acquired pneumonia, while not negligible, are much less severe than the consequences for missing the diagnosis of a pulmonary embolism or an early-stage treatable lung cancer. And so the probability at which we are able to accept that risk is very different between the 3 diagnoses. Similarly, the treatment thresholds are very different. The harms and the costs of prescribing antibiotics, while again not negligible, are relatively mild compared to the potential harms of anticoagulation and certainly chemotherapy. in the extreme example, which would only be pursued with very nearly to 100% probability. In between is this yellow range in which the clinician decides they simply need more diagnostic information, either to move above the treatment threshold or to move below the probability threshold for testing. Bringing these together, often diagnostic reasoning and management reasoning are spoken of as distinct phenomena. Really, these form parts of an integrated whole. Diagnostic reasoning, in some senses, is our own internal processes as we process the patient's data, generate our problem representation, match against illness scripts. Management reasoning occurs as we start integrating that, both with the wide range of possible outputs of management reasoning, all of the tests available to us, the many treatment options we can pursue, whether the patient should be admitted or sent home, how long to observe, and weigh our probability of disease not only against the various options in front of us, but also in light of cost considerations, patients' preferences and values, the constraints that we face in our health systems, our own risk tolerance, and the patient's risk tolerance and aversion. The final stage in the diagnostic reasoning process is reflection. Reflection is critically important both to cement the knowledge gained to enrich our illness scripts and diagnostic schemas, and also to improve the reasoning processes that we're employing. And I teach my learners to consider both, to consider the outcome and use the outcome to enrich illness scripts, to add to an understanding of the range of possible presentations and subsequent courses for the patient's diagnosis, but to reflect on their reasoning and decision-making based on the process employed. We all know that patients, despite the best possible treatment, sometimes have bad outcomes, and patients sometimes have extremely unlikely diagnoses. We should reflect on our reasoning on the decision-making strategies based on reflection on the data that was available at the time. What were the reasons for the diagnostic assessment? But were there pieces of data which were overlooked or underemphasized or overemphasized? Opportunities based on the data available at the time to assess a better probability or to make better management decisions as a result. So how does this actually work in practice? How can we teach clinical reasoning? As most people are probably aware, there's a range of educational activities which are associated with very different rates of retention of the material with which you're engaging. On the one end is what unfortunately you're doing right now, which is listening to a lecture, which tends to be associated with a very low rate of knowledge retention. On the far end is to practice by doing or to teach others, which again emphasizes the importance of early case-based education. Next is to teach the process. We can arm our students with the vocabulary to understand the processes they're engaging in, the difference and strengths and pitfalls of both non-analytical reasoning and analytical reasoning, but also the vocabulary of problem representation and illness scripts. One of the things that script theory has really taught us is the fact that knowledge structure, not just volume of knowledge or knowledge content, is really important for accuracy and success. And so early training in case-based education to start putting our knowledge in the context of illness scripts and cases is critically important for diagnostic improvement, as well as considering strategies for training in combined reasoning, as I mentioned, learning to use both System 1 and System 2 in tandem effectively. We can listen to our learners discourse to understand the stage of reasoning that they are employing in a given patient case. This comes from work by Georges Bordage, who described 4 patterns of research discourse in which students engage. And these patterns of discourse are really defined not just by the amount of data described, but about the types of semantic qualifiers that and structure that learners are using. There's reduced discourse, which is simply an acknowledgement of, I don't know. This is a very limited description of some concrete instances with no structure and relatively little data. Commonly, what we see is dispersed discourse. This is reflective of a learner who has obtained a lot of knowledge through memorization, but provides a long list of static diagnoses. The knowledge is abundant, but there's no clear direction or structure. And what you see is still repetition of a lot of concrete data about the patient's presentation. In contrast, elaborated discourse describes multiple qualitative terms that are more abstract than the patient's presenting symptoms. For example, here you see multiple discrete episodes with abrupt onset and extremely severe pain, abstract terms that help to paint a much more clear picture of a likely diagnosis and leads the learner in a very clear direction. And finally, compiled, which will often be seen in expert clinicians, the expert who skips almost past the abstraction to the diagnosis. And when we hear this from our learners, we really need to interrogate further. And what we hope to hear is elaborated discourse. The first two, reduced and dispersed discourses, are associated with a high likelihood of an incorrect diagnosis. In contrast, when we hear elaborated and compiled discourse, these have been found to be associated with a very high likelihood of a correct diagnosis. So let's see how this process, this iterative process of clinical reasoning, of the development of problem representations and subsequent hypothesis-driven inquiry come together. To take a simplified case of a 28-year-old man presenting with 3 months of low back pain, we immediately start to frame this to ourselves as a young adult with chronic low back pain. And that triggers multiple hypotheses: mechanical pain, traumatic injury, a disc herniation, inflammatory causes. And so we inquire further about some of these possibilities. Is there any history of trauma? Are there any radicular symptoms? James has no history of trauma, and he doesn't have any radicular pain or numbness. And so we add this into our representation and start considering a young adult with chronic non-traumatic and non-radiated low back pain. And so you see a similar differential diagnosis, but we've started to make space for some more detail around possible inflammatory causes as that rises in probability. And so we ask, are there any alarm symptoms for inflammatory back pain? James reports pain that it wakes him from sleep, is worse in the morning and after rest. And so again, our problem representation evolves to now consider a young adult with chronic inflammatory low back pain. Now we're focused in on the possibility of spondyloarthropathies, possibly of osteomyelitis, tuberculosis, of malignancy. And so we start inquiring for some of the enabling conditions which might modify the probabilities of each of these possibilities. James reports no history of IV drug use, no risk factors for tuberculosis, but he does describe a history of Crohn's disease for which he is not on medication. And so now we think about a young adult with Crohn's disease and inflammatory low back pain. And this leads us to a working diagnosis of a seronegative spondyloarthropathy, particularly ankylosing spondylitis. But we still need to exclude high impact can't miss diagnoses such as osteomyelitis or malignancy. And this would lead us to further both exam maneuvers and ultimately imaging, both to attempt to confirm our working diagnosis and to adequately exclude some of these can't miss diagnoses on the differential diagnosis. So with that, I'm going to turn the floor back over to Dr. Abdelnour to talk a little bit about how some of this theory is implemented into Healer.
Thanks. Thank you, Nate. I'm just going to share my screen. So a lot of what we've heard is the strategy, a framework that we can use to teach at the bedside with real cases. And I think working with real cases obviously has advantages where real cases really create this immersion, a perspective, a reality that helps learning and helps build these illness scripts and these diagnostic schemas. And always the goal at the bedside, based on what we've just heard from Dr. Stehauer, is really to focus on teaching problem representations, active data acquisition, thinking about illness scripts, thinking about combined reasoning, system 1 and system 2. But bedside clinical reasoning is challenging. First of all, cases are random. You can't really prepare. You can't ask for a case of an acute myocardial infarction. You just get what you get. And learners have a very different level of expertise. But so do clinicians, so do the educators and their ability to provide education and assessment. And also, each particular learner is extremely influenced by specific educators, and making students very, very sensitive to feedback. But one of the main challenges, as we all know, as we teach at the bedside, is time. There's just not enough time to teach, leading to a really limited deliberate practice experience. And so when we thought about augmenting the deliberate practice, we thought about virtual patient platforms. Now, virtual patient platforms need to be diverse and have a scalable library of cases with a lot of typical cases, but also uncommon cases. Data acquisition needs to be active. They need to go and get the data as opposed to read it in a case report or on a handout. And then there should be an explicit assessment of the distinct steps of clinical reasoning, problem representation, differential diagnosis, illness script confirmation, etc. And ideally, this should be automated, and we should be able to do it remotely. So to that end, we developed an NEJM Healer. Now, an NEJM Healer is a virtual patient simulator, or sometimes I refer to it as a bedside teaching simulator, where learners encounter patients and engage in these specific steps of clinical reasoning very explicitly, and are provided assessment and feedback so that they grow and they evolve. Now, each encounter in any NEJM Healer is broken down into 4 stages of data acquisition. What we all know is that residents go straight, or learners go straight for imaging or lab results before spending time getting history and physical exam. So to teach a more careful approach, we've divided the encounters into 4 stages. A triage stage where there's only vital signs and the chief complaint, which is shown here. And then there's a history stage where they can ask anything they want, a physical exam stage, and then a diagnostic stage. And at each stage, learners must actively select data that they think define the problem and can help build a differential. They must write a problem representation in the box here, and then they must start generating hypotheses. And we specifically teach them to combine System 1 and System 2 thinking. Almost certainly, early learners, we had a question about very early learners. Early learners will have almost no illness scripts, except illnesses they're familiar with from their daily lives. For example, almost everybody is familiar with COVID or the common cold. But the key here is to start training them in getting data and start training them in abstracting the data and the problem representation. Now, to generate hypotheses, we can start introducing these very early learners to diagnostic schemas, very simple schemas on what is the differential diagnosis of a runny nose? What is the differential diagnosis of a headache? So on and so forth. Things that don't necessarily require very deep knowledge, but really start engaging learners early in the reasoning process. Now, the reason we've broken it down into these different stages is because it allows us to capture the path to the diagnosis. It's not about the end result, it's about the journey. And so, for example, here in triage, the expert had these 5 diseases, and then as the expert went through the case, the differential narrowed. And at each stage in Healer, we capture the differential diagnosis and the problem representation, which really allows us to provide stage-specific assessment and an overall differential diagnostic accuracy, which is their ability to come up with sound differentials throughout the case, not just at the end. And also, by looking at how the problem representation changes from early to late, it allows educators to, provides educators with a window into the learning, into the reasoning of the learners. Specifically, did they select the right data? Did they abstract the data into the right syndromes? How is their discourse? Is it reduced? Is it dispersed? Or is it in fact elaborated? Now, as they go through the case, the history, physical exam, then after they looked at the chart, we asked them to think about their thinking. We asked them to think about how confident are they about the differential diagnosis. And so they need to rank, I'm very confident or I'm not confident. And we then also asked them, how demanding was this encounter? Was this so easy that you barely had to think about it? Because if that's the case, you may need harder cases, or maybe you just don't know enough. And so this assessment of the cognitive load can give us a very particular insight on the state of mind of a learner. After they've gone through all this, we give them a preliminary feedback on their data acquisition. How did they select the right data? And of the data they've selected, how many were appropriate. And so we give them an assessment on diagnostic, on data acquisition thoroughness, were they thorough in capturing all of the expert data, and data acquisition efficiency, how efficient they were. And by comparing these two, we can identify different phenotypes of clinicians, in particular this middle one here. These are learners that capture everything. And so they tend to be very, very thorough, but completely inefficient. These are learners that are shotgunning their way through the case. And then we actually give the learners the top 3 diseases of the expert. We tell the learners, well, in this case, the expert thought about pulmonary embolism, CHF, and asthma. And these are some of the key results that the expert used for the differential. We want you to first determine which disease or diseases do these findings in green make more likely. And learners here need to drag and drop each result into the corresponding circle. For example, a chest X-ray that shows bilateral infiltrates would be dropped into CHF as opposed to PE or asthma. And then they need to define which disease or diseases do these findings in red make less likely. So it makes them think about the distinguishing features of the data they require. After that, learners need to type in a management plan. And as we just learned from Dr. Stehauer, this is where there's an opportunity for educators to really start introducing concepts around probabilistic reasoning and how forecasting and likelihood of diseases drives decision making. At the end of the encounter, they're done, they've put in their differential, they put in their management. We ask them to perform an informed self-assessment of their problem representation and their management plan as shown here. This is a great opportunity for learners to look back at their problem presentations and read the expert's problem presentation and then perform a self-assessment. And at the end of the encounter, we provide assessment around data acquisition, again, thoroughness and efficiency, diagnostic accuracy. On their lead diagnostic, did they identify the final diagnosis as did the expert? Before and after the illness script, the Venn diagram illness script instantiation, and then their overall differential diagnostic accuracy. We also provide them a score on their illness script concordance. How good did they drag and drop the data into the Venn diagram compared to an expert, which is an assessment of knowledge and assessment of instantiation. And then we show back their self-assessment. Now, when you have a group of students that are going through these cases, students can then look at their performance relative to their peers. And so here, for example, the learner Anna can see how they performed compared to the rest of their class, both in their differential diagnostic accuracy, the lead diagnostic accuracy, illustrative concordance, and their self-assessment. This gives powerful insight to learners to calibrate and see what they need to do, but also to educators. Educators can get the same view on their group of students. So if you're an educator with students that are spread out across the campus, for example, you can easily track learners' performance and progress in Healer. And you can even download a detailed report that includes all that information and much, much more to really hone in on the particular performance of the learner. Now, what to do with some of these results? Well, these are some of our suggestions. You can separately assess reasoning and knowledge. So, for example, if a learner has a low differential diagnostic accuracy, so let's say in the lower 75th, under the 75th percentile, and their illness script concordance was low as well, this is a learner that needs knowledge. They don't know where to drag and drop the results in their diseases, and they don't know what diseases to activate. So here we suggest teaching diagnostic schemas, teaching how to approach problems. Now, if their differential diagnostic is low, meaning they don't have a good differential, but they know the diseases and the Venn diagram, these are learners that did not activate the illnesses, although they know them. So these are learners where we encourage you to look at their problem representations. Because if, again, like Dr. Stehauer said, if learners did not abstract the data and write a good problem representation, they're not going to activate the right illnesses. Similarly, if you put wrong information in a Google search, you're not going to get the results that you want. And then you have learners that have a high differential diagnostic accuracy. So some learners with a high accuracy may have a low illness script concordance. These are learners that are acting more on system one. They're recognizing the illnesses. They're using their past experience, but fundamentally they don't know the diseases. these are learners that you want them to get familiar with. They need to learn particular diseases. And finally, you have folks that are very familiar. They have a high knowledge and high reason. Now, how to integrate Healer in a curriculum? Well, what we suggest is to start integrating a clinical reasoning education on day one of school, whether it's medical school, PA school, a nursing school. And that's because the process itself needs to be taught, not just the knowledge. And you can start teaching how to acquire data, how to write the problem representations as early as day one. And by incorporating incorporating that information throughout a curriculum, you could really, in a stepwise fashion, get learners used to the reasoning process, get learners used to combining system 1, system 2 thinking, developing diagnostic schemas, thinking about probabilistic reasoning, and really drive diagnostic excellence. Now, one concept that we've been also discussing is these deliberate practice units. Again, practice makes perfect. We can teach everything in the world. If we don't apply it, we don't learn it. And so in these deliberate practice units, we have a didactic content, healer cases or case-based education, and then a debrief and assessment and feedback, and then more, and then iteration on that concept. And by having these deliberate practice units spread out across the curriculum, you can start exposing learners to the reasoning and knowledge according to the level. For example, early deliberate practice units early in the curriculum could be all centered around the problem representation and data acquisition. You could tell your learners, don't worry about the differential diagnosis. Don't worry about the management. We want you to start writing problem representations in the right way. And then as learners progress, these units can become more focused. For example, you could have a deliberate practice unit around chest pain or diarrhea, or around management of pulmonary embolism. And now to provide enough cases, we've developed a case difficulty rubric. So the difficulty level of cases are defined by how prevalent or how common is a disease. If it's common, then it's a 1. If it's a rare, it's a 5. The presentation, is it a typical presentation or an atypical presentation? Is there noise? Is there a lot of sort of confounding data, a lot of red herrings? And are diagnostic lab results present? For example, in the case of pneumonia, is there a chest X-ray or not? The presence of a chest X-ray would make that case easier. And then by compiling all that information, we get these total scores, which allows us to define whether a case is going to be easy, medium, hard, or very hard, but also at what level, what learner level these could be directed. And all of this is available in Healer when educators are making their assignments. I'm going to pause here for questions, and thank you.
Great, thank you. Thank you very much to both Dr. Stehauer and Dr. Abdelnour, and thank you, all of you for your attention. And we've got a few great questions already. Please keep them coming in. The two questions that we have to start with are actually pretty closely related. So one, in the chat about whether or not it's better to start clinical reasoning training, start using a tool like NEJM Healer before or during their basic science learning, or only after they've completed that basic science. And I think you addressed part of that, Rajali, and Dr. Stehauer, but it would be great to elaborate on what you have in the chat. And then a new question coming related to that of how to implement Healer for year 1 and 2 students in CBL curriculum with a session like clinical reasoning. And this is from someone who uses mini scenarios relating to the main course and provides an environment to enhance their differential diagnosis capabilities over time. Is this form of assessment suitable to them, and do their needs need to be tailored?
Maybe I'll take that question. I think what's the as educators, you'll have the flexibility of deciding how to use the cases based on your needs. So, for example, if you're working with very early learner levels, where differential, where again, the differential diagnosis, you know that the learners don't have the knowledge to produce the good differential diagnoses. The learners could be told specifically not to worry about the differential, but really think about gathering the data that they think is relevant and then writing it in a problem presentation. The assessments then learners could then be told to only focus on self-assessing their problem representation. So when they get at the end of the case, they could read what they've written as their problem, and then they could read how the expert wrote the data for that wrote the problem representation for that same case. And by comparing what they've done to those of the experts, by performing the self-assessment, that provides them immediate feedback and calibration. And so, and learners could be told, we don't expect you to have a thorough differential diagnosis for a patient with chest pain, for example, let alone we don't expect you to know the management. So don't focus on them, enjoy, try, but really focus on the early parts. So I think there should still be, Healer is not meant to be a tool that's given to learners for them to just practice on their own. There should be this is a tool that's there to support educators and allow them to engage in teaching clinical reasoning and provide all the feedback.
And I just add very briefly that we've got programs that are using this both for very, very early learners and for advanced learners quite successfully. And we've got programs that are using it similarly. We've got programs that are using it much more in a sort of formative assessment model, right? Where you might go through the cases with the students, right? And, have use this as the lecture, essentially, walking through a case, and other programs that are using it on the extreme other end for, high stakes assessment for learners, right? And so there's a big mix there, and we're happy to, our team is happy to work with institutions to figure out what their needs are and where Healer fits in best within their program.
Thank you. May I ask, what can you tell us about the cases that you have on NEJM Healer? And basically, what areas of medicine is this cases focused on? And perhaps give us some example of how other institutions have deployed this platform in their schools.
Sure. So I'll talk about the cases. So right now we have 100 cases around adult medicine. And that range with up to 9 presentations: chest pain, abdominal pain, dyspnea, both acute and chronic presentations, and of varying ages in the ICU, in the outpatient. And then we have coming up in summer, we'll have pediatric cases that actually Dr. Stehauer is leading the development of, but also cases in dermatology, cases in psychiatry, cases and cases in neurology. In terms of how it's being used, Matt, maybe you can take that question. You have a better pulse on the market.
Yes. So again, the usage is extremely varied, right? In terms of where it fits in. We've got people using it in individual courses. We've got people using it for pre and post testing, right? So you're doing a course, you want to get a sense of what students know coming in, what they're able to do, and then you want to do a sort of post-test afterwards to see if they've improved, right? And along the way, some of the data I think that Dr. Abdulner showed very briefly really gives one a sense of how the class is doing as a whole and where there may be outliers, right? Learners who need more help and more practice. And Healer can both help to identify that, but then also provides the platform to provide them with that more practice. So I think that that's really useful. Dr. Abdulner and Dr. Stehauer, it might be worth hearing a little bit about how the cases in NEJM Healer differ from cases that are frequently created by physicians, physician educators working in a program, and from other simulations that are out there and that are available. I'm thinking, for instance, of just how much more granular the data are and the feedback. So anything that you want to add on that front?
I'm happy to mention a few pieces that I'm particularly excited about, and turn it over to Raja Ellie. I think Matt alluded to the granularity of what's available and what's available for for feedback. And when we talk about assessment, we think about assessment as a very high level. What sort of data about your current performance will predict your future performance. We also think about the sort of very granular assessment that a coach standing at your bedside would offer. And I think that's the sort of thing that that Healer provides in terms of detailed feedback on what is the relative diagnostic weight of these multiple possible pieces of data that could have been selected. And how does your ability to compare and contrast all of those and aggregate those compare with how an expert chose to do that? And I think that provides much more detailed insight, not just into a general need to improve or gain knowledge in an area, but specific strategies that can be utilized to gain and improve in a given area of reasoning or in a given content area.
Thank you very much, Dr. Stierhauer. There's another very good question in the chat. Is there any study which compares using a tool like NEJM Healer as opposed to the normal clinical bedside teaching that we do in a hospital for clinical reasoning? Does it lead to equivalent type of learning performance?
Go ahead, Nate.
There are a few studies that have looked at, well, there are a lot of studies that have looked at various virtual patient formats. Obviously, those sorts of studies are highly dependent on the quality of the virtual patient simulation that's being utilized. Certainly, there's lots of evidence, though, to suggest the potential efficacy of virtual patients. And there are a few studies that try to show some equivalence in terms of, can you replace pieces of clinical experience with a virtual patient? I would say, though, that that's not quite the question I would be asking, because I don't think any of us would advise that this be used as a replacement for clinical experience and bedside teaching. This, I think, has much more to do with the ability to implement early in the curriculum and the ability to scale, the ability to augment clinical experience with additional patient exposure, and something that can be done individually and with the detailed feedback that Healer can provide, but without the continual presence of a attending physician at the learner's side.
Yes, I agree with you, Dr. Stierhauer. Rather it being a replacement, perhaps it will be an excellent supplement to clinical teaching, as you said, due to time's constraint and many other constraints. This would be a very good supplement that can build students' confidence and practice together with clinical experiences. Thank you for that very good question. Any other questions or comments from the floor?
Rajali, if you'll go to the last slide there. Yeah, so just again, our thanks to Dr. Tay for hosting us today, and to all of iGroup. And just this is a reminder, this is how you can contact your local iGroup representative. All of the information is here. I understand, Dr. Tay, that Dr. T, that these slides will be shared with all the attendees. So you should get copies of these so that you've got this important follow-up information. We'll also have a special offer for people who purchase Healer between now and September 1st. We're offering 20% off. For those of you who attended this session today. So again, reach out with any additional questions, any questions that come up through iGroup that they can't answer immediately. I know that they'll come to us, and we love the opportunity to work with educators to answer questions and to see how this can fit into their programs. So thank you. Anything else from you, Dr. T? Anything that I missed? We missed.
No, I think we're very good. We have some thank yous from our participants as well. Yes, thank you, everyone. Matthew, Dr. Raja, Dr. Nathan. It has been a wonderful session, and I think our audience have also been very participating with the questions. And yes, we will share the recording as well as with the slides with everyone. And I would highly appreciate if our participants can fill in the feedback form as well, so that we could keep in touch and do better the next time as well. Thank you, everyone, for your presence.
Absolutely.